I'm filling in today for Dr. Podolsky, but I just wanted to introduce our clinical grand round speaker for today, Kirk J. Woodring. He's a master of social work and professor at Smith College School for Social Work. And he's gonna be speaking with us today about the increase in self-inflicted suicide deaths, and kind of a way to decrease the clinician's fear of engaging with individuals who experience suicidal ideation. Um, let's see, is Kirk here
I'm
today?
right here. Can you hear me?
I can hear you.
Okay, terrific. Well, thank you very much. So, again, Kirk Woodring. I'm a clinical social worker. Live in Massachusetts and worked for a while in Connecticut. Did some work with ECHN down in Connecticut, as well as Waterbury Hospital, where I met Dr. Podolsky. So, we have some history together. We've done a lot of work together, and I'm really pleased to be here this afternoon. This is a pretty difficult topic. It's one that I've done a lot of work, both clinically with folks who are suicidal, as well as just personal experiences with family members who have died by suicide. And so it's a topic that I think is very, very near and dear to my heart, and one that I hope I can kind of share some stories and ideas with all of you this afternoon. Let me just say that a lot of this presentation is going to be directed at, having conversations, talking with folks who you might be concerned are suicidal, or who you may just even not know, but want to ask or want to have a conversation with them about that. The music that I did on the intro was a song by Pink Floyd called "Keep Talking," and I think that's what we want to do, is just keep talking. We need to get our clients and our consumers, the folks that we're working with, and our family members engaged in conversations about suicide. And it's a very difficult topic. So just to kind of set the agenda for the next hour or so, I'm going to talk a little bit about introduction to suicide risk, kind of framing it a bit around pre and post COVID, and we'll talk a little bit about some of the CDC statistics around suicide and suicidal ideation, suicide risk. I'm going to talk some about what to look for in suicidal individuals. So what do we see in folks who might be contemplating suicide, who may have attempted suicide, who we're concerned might attempt suicide? And then we'll talk about some kind of rapid engagement techniques to use for folks who are who you're concerned about their risk level. We'll talk a little bit about how to engage them in conversations so that they're more likely to give you valid responses around their suicidality. One thing we know about folks who are engaged in any kind of stigmatized behavior, whether that's substance use, whether that's criminal behavior, suicidal thoughts, they're not always honest with us. And so we want to engage them in conversations so we're more likely to get good, valid information from them. And then we'll have time for questions. It's unfortunate that we're on Zoom. I would much rather be in an auditorium meeting with all of you and talking with you directly. But hopefully, if you have questions, maybe we can have those. Maybe you could. I won't be able to see them, so maybe Darcy or someone could just be watching those if there are questions, and then let me know, give a shout out, and we can stop and answer a question during the presentation. Otherwise, we can hold them off until the end, and that's fine. We'll have time to talk a little bit at that point. So, one of the things that I think is really important to consider in this whole topic is the fact that people have a very difficult time talking about suicide. In fact, even saying the word suicide can be difficult. And I want you to think about this. And if we were in a large group together, I might actually ask you to say the word suicide, but you can do that now if you want. Muted is fine. But I want you to think about what that feels like to say the word suicide. Where do you notice that word kind of hitting? Does it trigger anything for you? Does it get stuck in your throat? One of the things that I have found in the years of training that I've done with clinicians and psychiatrists, social workers, mental health counselors, is that they have a very difficult time, even in sessions with their clients, saying the word suicide. And so hopefully by the end of this, you'll feel more comfortable with the word suicide, with saying the word suicide, with asking questions about suicide. All right. So one thing that we do know is that there's no iatrogenic effect to the talking about suicide. So if you use the word suicide, if you're asking about suicide, you're not going to cause somebody to become suicidal. In fact, the opposite is true. If you talk about suicide for somebody who is suicidal, they're actually going to be relieved that you're asking questions and that there's an opportunity for engagement in a conversation with them. So let's talk a little bit about the suicide epidemic. Now, in 2013, the U.S. Center for Disease Control, the CDC, for the first time ever, recognized that suicide was a national epidemic. And that was because from around 2008, right up through essentially the last couple of years, suicide rates had been increasing pretty significantly. And around 2009, 2010, they really took a steady turn upwards. And the CDC recognized in 2013 that suicide was an epidemic in this nation. And so they targeted, as an epidemic, they targeted a lot of resources and a focus on suicide prevention. You can see with the new suicide hotline, the 988 number, that's an outcome of some of the work that the CDC had done around identifying suicide as an epidemic. But in 2020, you can see here that the statistics, and 2020 is actually the most recent year the CDC has publishable results. They do have results from 2021, but they haven't published them yet. They usually publish those in November. So, so we'll have a little better idea of kind of post-pandemic or mid-pandemic what the numbers look like. But in 2020, we had 12.5 million people, adults, seriously thinking about suicide. Those are adults. One thing we know during the pandemic has been that there are significantly higher rates of individuals presenting with depression and anxiety. In fact, in one study, I believe over 50% of adults in the United States had a diagnosable anxiety disorder or depressive disorder. So over half the people in the United States are experiencing anxiety and depression, which are two of the diagnoses that lead to suicide. There are others as well. Bipolar disorder, substance use disorder is certainly very high in individuals who've died by suicide or who attempt suicide. But you can see that I think partly because of the pandemic, the rates of anxiety and depression have pretty much skyrocketed. One thing too, when I'm talking about suicide and kind of the expected way of talking about suicide now is that people don't commit suicide; they die by suicide. It's just a little different way of kind of languaging that. But linguistically, dying by suicide is the preferential way of talking about suicide, not committing suicide. So, almost 3.5 million adults made a plan, and 1.5 million adults attempted suicide. We'll talk about, as we go along here, whoops, didn't mean to do that. Go back to that. As we go along here, we'll talk about the rehearsal process for folks who are attempting suicide or who have suicidal ideation. And so, you have many more people who actually attempt suicide because they're rehearsing suicide in some ways than actually end up dying by suicide. On the right there, you can see the unintentional deaths is the highest. That's the number of deaths, percentage of deaths in the United States. 72.2% of adults, actually of all age groups, in 2020 died by unintentional means. So that could be a car accident, it could be a fall, it could be an illness, it could be many number of things that are unintentional. But suicide is really right up there near the top, and it's always in the top 10. I think there's another slide in a bit that talks about the top 10 reasons for death, causes of death in the United States in 2020. Suicide, 16.5% of all deaths in the United States were by suicide in 2020. That's almost twice the number that were by homicide. If you think about it, you're watching CSI or Law and Order. A lot of those television shows, a lot of the shows that we see on Netflix and elsewhere are about murders, right? We rarely see discussions on our TV shows and on our movies around suicide. It says something about the stigmatizing aspects of suicide, I believe. We don't feel comfortable talking about suicide. We prefer not to kind of look directly at suicide. And so despite the fact that twice the number almost of people in the United States in 2020 died by suicide as died by homicide, there's a lot more attention paid to homicides. So in 2020, again, we're looking at the number of suicide attempts, hospitalizations for suicide attempts. These are, related to hospitalizations. 4 hospitalizations for suicide attempts for every suicide death. So, for each person who dies by suicide, 4 people are hospitalized for an attempt of suicide. 8 people are visiting the emergency department related to suicide. 27 people self-report suicide attempts. So they may not end up in a hospital and emergency department, but they're coming in, or they're coming someplace, it's the physician's office, maybe, or a counselor's office, to report that they've made an attempt. And then 275 people seriously considered suicide. And seriously considered suicide means that they are working on a plan. They have the means to attempt a suicide, but they may not have actually made the attempt yet. So for every death in the United States by suicide, 275 people are actually considering suicide. I think it's interesting to consider that suicide rates are much higher among men than among women, 4 times higher among men than among women. And that even though men are not quite 50% of the population, about 80% of all suicides are by men. You might wonder about that. And in fact, you may have clients that you're working with and think, wow, it seems like more of my female identified clients I'm dealing with their suicidal ideation than with the men that I work with. And that may be true because women actually make significantly higher numbers of attempts of suicide. In fact, anywhere from 2 to 3 times the number of attempts at suicide as men, and yet men are 4 times more likely to die by suicide than women. Part of that is because men tend to use more lethal methods of suicide. They tend to use firearms significantly more often than women, and so if you're using a firearm to make a suicide attempt, you're significantly more likely to die by suicide using that method than any other method, and so that's in large part why we're seeing more men who are successful, who are dying by suicide, rather than who are just making the attempts. Firearms are the most common used method in suicide. And again, more men than women use firearms. So about 53% of suicides are by some firearms, usually a handgun. And if we look at a map of the United States and we look at kind of the rates of suicide across the country, it's not surprising that we see rates of suicide significantly higher in those states where gun control laws are much more lax. So in the kind of the central western states, in the South, certainly up in Alaska, northern states. So we see these areas, these spikes. Florida has high rates of suicide. So where there are more lax, fewer rules around gun ownership, the rates of suicide are significantly higher. We also see rates of suicide higher in the kind of northern states, again, Alaska, North Dakota, Maine, in large part because they're more rural, and also because, in the northern states, as we're moving into now, as of yesterday, we're moving into those darker days where if you go further north, the nights are much longer, and there also tends to be much more social isolation. So you have fewer ways of connecting to resources if you're living in a state that's more rural and northerly than in a more industrial state, someplace like the Northeast, Massachusetts, Connecticut, New York. Suicide rates in the Northeast, with the exception of really Vermont and Maine, tend to be pretty significantly lower than the rest of the country, partly because of gun laws, gun restrictions, and also because of access to resources in those areas. I think another interesting statistic is that people 85 years and older are at the highest risk for suicide. Now, if you look at the CDC's statistics around causes of death by age group, and you look at over 65, that age group, you don't see suicide as being in the top 10. And yet, individuals who are 85 years and older, especially men who are 85, white men who are 85 years and older, 65 years and older, have much higher rates of suicide than really any other age group. And the reason for this is that there are also obviously other reasons that people who are older die. Higher rates of cancer, higher rates of heart disease, cardiac disease, and yet those numbers for suicide are significantly higher. In fact, 14.2 per 100,000 for individuals who are 15 to 24, and 20.9 per 100,000 for folks who are 85 years and older. There's a lot of reasons that we know this is the case. People who are older tend to be more isolated. They tend to have more kind of chronic illnesses and diseases, more, struggling with more pain. They may not have kind of the sense of connection with individuals in their community, loneliness, isolation. They've probably by that point retired if they were working, and for a lot of folks, work is where they have their social connections, and so they've lost that, and some of their identity is suffused with their their experience as a worker and at work, and so they lose that those connections. And so I put this up there as just to be thinking, to get you thinking about where is the risk. Who is the most at risk? Certainly young people are, and yet our older adults are really significantly at high risk. So we look at the top 10 causes of death in 2020. Unintentional injury is far and above the highest number of deaths. Over 80,000 individual deaths per year are by unintentional injury, and yet we go just below that, and even though it's significantly less than unintentional injuries, we have suicide, and then we have homicide, followed by kind of everything else. Heart disease, malignant cancer. COVID-19 in 2020 was right up in the top 10, right? It was number, I think, 6, but not nearly as high as the number of deaths by suicide. And if you look at the graph down here, kind of at the bottom, you can see that suicide rates began really increasing and continued to increase and increase slowly but steadily right up until the last year or couple of years. Unintentional injuries, I think it's interesting, went really just skyrocketed in the last year. And we're not really sure. I'm not really sure of what the causes of that would be. My sense is it probably is related to the pandemic, but we probably won't have good information on that probably for at least a year or so. So interestingly, we enter into the pandemic in 2019, 2020, really 2020 in March is when we began the isolation, the stay-at-home orders were in place. And I would have assumed and did assume at that point that we were going to see really skyrocketing numbers of death by suicide. And in fact, what happened was we actually saw a decline in suicide rates. In most overall, we saw a decline in suicide rates, not with some specific demographics, but overall, we saw a decrease in suicide rates. So between 2018 and 2020, there was a decline of about 3%, even though we had COVID. Now, I was talking to some folks about that, and was sort of curious about that, and wondering like what would be the cause of that. Part of it I think was that even though people were isolated, they were at home, they also often had others around them, family members around them. They were kind of sheltering in place with other folks. And so that's a protective factor. When you have other individuals around you, people around you, that's a protective factor. Even if you may not necessarily get along with them, it's still protective to have others around you. I think the other thing is that we saw a more difficult time accessing means for suicide, particularly firearms. So being able to go out and buy a firearm during the pandemic was significantly more difficult than it was pre and post pandemic. And so access to firearms, if you didn't have one already in your home, access was more difficult. And if you did have one in your home, you were with other people, and so you were more likely to not be able to use a firearm. And so we saw a decrease in suicide rates. We also know that as a kind of an unintended consequence or an unexpected consequence of COVID was a pretty significant increase in the use of telehealth, particularly telepsychotherapy. And so for individuals who were able to access teletherapy, they didn't have to leave their house. They didn't have to travel. They didn't have to move. It made ease of access to therapy significantly greater ease of access. And so that's, one kind of protective factor of the pandemic was that access to telehealth, to teletherapy. And we did see a real increase in the use of psychotherapy through telehealth. And so people were more engaged during that time. And interestingly, I think suicide rates historically dropped during a crisis. We saw that after 9/11 in 2001 when we had the 9/11 attacks. We anticipated that there might have been an increase in suicide rates at that point in time, but in fact, there really wasn't around that particular event. We didn't see those rates increase. We actually saw them drop a bit. So the caveat to this is that there are other things to consider, right? Rates for people who were aged 10 to 34 were higher in 2020 than they were in previous years. So that particular age range went up. And we saw this, and I know that there's a clinical grand rounds in a couple of months around adolescent and children's suicide, which I think, I won't touch on that too much because I know you'll get more information on that later. But I think that, it is pretty critical to think about what's happened to our youth during the pandemic, and the rates of anxiety and depression are really significantly higher than at any other time in history. And so we do see that there was a bit of an increase, particularly in younger people. Males aged 10 to 14, that very young, pre-adolescent and young adolescent increased by 13% during the pandemic, during 2020. And age 25 to 34 went up to by 5%. And then females 15 to 24 increased by 4%. So while we saw an overall decline in rates of suicide, there were specific age groups that really did increase, particularly those younger folks. I think another thing to consider too is that there may be delays in investigations related to suicide, in investigating deaths. Part of that has been that the coroner's offices, medical examiners' offices were in many ways overwhelmed by the pandemic, and so they did not necessarily spend as much time as they might have on other causes of death. I think the other thing to consider about suicide, and this is more of a kind of sociocultural issue, is that there are some parts of the country, particularly where suicide is probably counted, underreported at the medical examiner level, at the coroner level. Part of that is because of the stigma that's associated with suicide. So in kind of very religious communities, suicide may be undercounted, underreported, and unintentional death may be coded as an unintentional death, which again may speak to the increase in the unintentional death rate in 2020. So who attempts suicide? This particular kind of statement is one that really, to me, encapsulates somebody who's suicidal. When an individual's intolerance for the intensity of stress and pain that they're experiencing exceeds their capacity and resources to overcome the problem. That's essentially it. In the work that I've done and what I see. Certainly in folks who have who are chronically suicidal or have suicidal ideation and practicing over a long period of time. Less maybe so for folks who are, more just kind of reactive in terms of a suicide attempt, and tend to maybe make it an attempt that is more spontaneous and less planned. But for many folks, it's really this intolerance for the intensity of stress and pain that they experience. And that pain could be physical, it could be medical. Back pain is, chronic back pain is actually a very high risk factor for suicide, any kind of chronic pain, but it can also be mental, emotional pain that is being experienced. And that pain, that stress exceeds the capacity and the resources to overcome the problem. So when you have fewer resources, you don't have to have quite as much pain and as much stress to make an attempt and to be, to actually be successful at your suicide attempt. I think warning signs to consider, probably many of these, but it's important to consider them, to look through them, to have that available. Talking about wanting to die, of course, is something that's always we want to be paying attention to. Previous attempts, family experience of suicide. I think another kind of under-recognized symptom of suicidal ideation is really the acting unusually agitated or anxious or reckless. I was actually talking to a clinician yesterday, and she was discussing an experience that she'd had at work in a large agency she'd been working in. And she'd noticed that one of the workers in this agency was unusually pacing. He'd been kind of walking around the office, much more so than usual, really agitated, psychomotor agitation. She thought it was really unusual, but she didn't ask a question about it. I mean, this went on for a few days. And the individual then ended up dying by suicide just less than a week later. And, she and I were talking, she said, if I had thought about that agitation, if I'd really looked at that as being something unusual, clinically significantly different than what he typically would be expressing. I might have asked a question to him. I might have stopped him. I might have asked him if he was okay. And she said she actually then, because of that, began to really ask questions in the lunchroom of folks who she was worried about. And the initial response to her was one of kind of rebuffing her and thinking that she was a little odd. But as she stuck with it and kept asking people about, how they were doing, were they okay? She found that they were much more willing to open up to her about their concerns about what they'd experienced with their coworker, but also their concerns about themselves. And so as we kind of come back to working, in person and away from the remote world, it's important to be paying attention to your coworkers. I mean, we work in the behavioral health industry, and I think that we're at very high risk ourselves for stress and for depression, for anxiety, and just that alone increases our suicide risk because of the kind of stress and pressure that we're under ourselves. So it's important to take care of each other and to be paying attention to each other as well. Thomas Joyner is a psychologist at the University of Florida, and he's written a lot about suicide. He really became interested in suicide when he was, I think he was a junior in college or maybe a sophomore in college, and his father died by suicide. And he has spent his career really trying to understand what was behind that. He could not understand how his father could possibly have been in such a state that he would make a serious attempt and then actually die by suicide. And so Joyner sort of distilled his theory around suicide into this Venn diagram. And I think it's helpful to consider when you're looking at suicide risk and when you're looking at who does attempt suicide. And so, starting over on the left side of that Venn diagram, you have thwarted belongingness, the sense that I'm alone. Certainly, the pandemic has created that in and of itself, right? I mean, many people have felt alone during the pandemic. They've been disconnected from their belongingness. And so that alone kind of sets up some suicide risk. But the feeling that I'm alone. Another big piece is also that I'm a burden. So not only am I alone, but I'm a burden on others. That perceived burdensomeness, and it might not be real. And I think that's important to consider as well, that there's a lot of distortion that goes on around folks who are suicidal. They have distorted thinking around their isolation, around their burdensomeness. They might not actually be a burden on others. And if they ask that question of people that they know or that care about them, they might actually get a very different response, but they feel like they're a burden. Then there's the capability for suicide. And this is where rehearsing suicide kind of comes into play. We don't often see individuals really suddenly become suicidal and have never had suicidal ideation and have never attempted suicide and then suddenly are successful at dying by suicide. What we see is more often, we see people who begin to kind of dip their toe into the water. They want to check it out. I'm feeling these feelings. They've been going on for a long time. I want it over. I'm feeling alone. I'm feeling like nobody cares about me. I'm a burden on others. So they begin to make attempts. And attempts typically, like any rehearsal, you start not being so good at it and you get better. And so over time, people who are chronically suicidal get better at the attempts that they make. And I think that's a caveat that we need to remember when we're working with individuals who are chronically suicidal, who are struggling with personality disorders, particularly individuals who've been diagnosed as borderline personality. I've heard clinicians, when I've worked on crisis teams, say, oh, he's just a borderline. He does this all the time. He's just looking for attention. That kind of dismissiveness is really leads to further stigmatization of not only folks who struggle with borderline personality disorder, but also folks who are suicidal. And so, what I would say is when people make attempts, it's important to really pay attention to what kind of attempt it was. Was it a near lethal attempt? Was it an escalation in the type of attempt that has occurred in the past? If you know somebody has made attempts before, maybe they've done some cutting and suddenly they've then taken a bottle of pills, that's an increase in the lethality. And so you want to pay attention to that with the folks that you're working with. Are their suicide attempts are their rehearsals getting better and better and in terms of their likelihood of dying by suicide? And then you have to have a desire for suicide, right? In the middle of that Venn diagram, you have the desire for suicide. So you have to want to die. That's not easy. Wanting to die is not easy. Dying by suicide is not an easy thing to do. Psychologically, it's not easy for anybody, even for folks who wish themselves to be dead. It's a very difficult process, and so that desire has to be there. The person has to desire to be dead, and to not want to continue on with their life. And then in the very middle of that Venn diagram, where everything kind of comes together, you have the suicide or the near lethal attempt at suicide. So when you're asking questions, when you're working with folks who are potentially suicidal, you want to be looking at these things: the thwarted belongingness, the perceived burdensomeness, the capability for suicide, and the desire for suicide. Those are questions you want to be asking about. So Darcy, I don't know, has anybody had any questions at this point that you can see?
No questions.
Okay, great. So I'll keep going, and but if there are questions, feel free to just send them to Darcy or put them out there, and I will. I can answer them. So engagement, keeping suicide in the conversation. As I said before, talking about suicide is really, really difficult. It's hard. People don't want to talk about suicide. As a clinician, if you're doing an hour-long psychotherapy session or an hour-long session with a client, the thing that you probably are most concerned about is that doorknob comment at 46 minutes after the hour, where your client says, I'm thinking about killing myself. I just want to die. Because that means that you have an obligation to do something with that, right? And so we try to oftentimes, and this is, I think the last thing we want to do is we try to stop talking about suicide. We try to keep our patients, our clients from talking about it, especially towards the end of the session. And yet, if we were talking about suicide during the session, at the beginning of the session, throughout the session, if we were having conversations about keeping suicide in the conversation, we probably wouldn't have those doorknob comments, because we'd be able to do some intervention earlier on in the session that might actually keep them from having to get more intensive treatment. In terms of what we are really absolutely imperative for us to do as clinicians, we know that we treat the most seriously ill people. I'm sure that all of you have individuals who are struggling with substance use, who are struggling with anxiety, struggling with depression, struggling with family. And these are the folks who are coming into treatment. And so we know that they're probably the most dangerously suicidal folks, because they're in treatment with us and we know what their risk factors are. In fact, it may be that the folks that aren't in treatment are even more dangerously suicidal because they're not talking about it. But we know that these folks that we're working with that are talking about their suicide risk we have an obligation to listen to them and to work with them and to keep the conversation going with them, to keep talking. We don't always know how suicidal somebody is unless we actually ask the questions around their suicidality. So rather than avoiding questions or speaking euphemistically about suicide, having direct conversations with individuals about their suicidality is really the way that they're going to disclose and open up about that. Being confronted directly about suicidality, really about anything, if it's done in the right way, allows disclosure in a way that they might not, you might not normally see in just a normal conversation. So we have to keep it in the front of the conversation. And the real imperative is, as clinicians, we have to prevent our patients from dying by suicide. Now, that's not to say that it doesn't happen, because it does. And, it's unfortunate. If you think about depression as being potentially a terminal illness, just like cancer or heart disease, somebody who's struggled all their life with depression may die because of that, despite all the interventions that we can provide, the best practices, the best medication. They may actually die by suicide or die for some other reason because of their depression. But we need to try and help get people through that 15-minute crisis that occurs where suicide risk is the highest. When somebody is really going to make that attempt, they're so hopeless, helpless, that they're ready to just die. Their desire for suicide is high. So it may mean that we have to facilitate hospitalization. And there's a little kind of a piece about hospitalization that I think is important to know. Hospitalizations do prevent people from dying by suicide in large part. That's not to say that people don't attempt and actually die by suicide when they're in the hospital, but they're very less likely to do that because of the protective factors that exist in a hospital. The problem, though, is that being hospitalized on let's say, a locked inpatient psychiatric unit doesn't necessarily decrease your suicidal thoughts. It just protects you from them, and it gives you supports around those feelings and getting some assistance from those feelings. So you may continue to be suicidal and think about suicide throughout hospitalization, maybe for days, but you're protected from the attempts because of the environment that exists, or you should be. And I think that's important because it protects people from acting on those suicidal thoughts until the crisis has passed. So getting somebody hospitalized, even in the absence of a prior hospitalization, can be very protective for them. I think it's always important when you're doing a suicide risk assessment, even a rapid suicide risk assessment, to be thinking about the protective factors that exist, not just the risk factors, because protective factors actually mitigate some of the risk, right? And so there are individual protective factors, interpersonal, psychiatric, psychodynamic, individual protective factors that folks have. Resiliency is a protective factor. Someone who has been able to bounce back time and time again from trauma, from illness. That's a protective factor. That resilience is a protective factor. Relationships that they have, interpersonal relationships that they have in their lives, partners, spouses, family members, relationships with animals. I can't tell you the number of folks that I've met with who have had very high risk of suicide, and yet they've identified their dog or their cat as a protective factor. They would never leave that animal alone, and so they're not going to die by suicide. The thing to look for then is what happens when they lose that relationship, right? So whenever that protective relationship is lost, whether it's a person, an animal, you need to be thinking about that as a risk factor. What are the community supports that the person has in place? Do they come to a clinic? Do they come to get methadone every day? And so that's a community protective factor. Being amongst folks, are they in a group that can be helpful? And then the larger societal protective factors, that might be religion, it may be other larger factors around access to resources in society that they have. So being able to immediately get assistance or very quickly get assistance is a protective factor. If you're in an urban setting compared to living in an indigenous peoples reservation in Montana where getting assistance might be hours away. So thinking about those protective factors, I think, is always important, and including them in your assessment is critical. So talking about kind of how to ask questions, I'm gonna share some rapid assessment validity techniques that a psychiatrist from New Hampshire, Sean Shea, has written about. And he wrote a book called The Practical Art of Suicide Assessment, which is a great tool for substance use clinicians, particularly for mental health professionals. He really kind of distills the process of questioning around suicide, and all of his work has been around how to ask questions for folks who are suicidal or who are at risk of high risk behaviors. So we'll start out with the first three, and the first one is called shame attenuation. And shame attenuation actually is a lot like one that we're going to talk about in a few minutes called normalization, but it's a little different. Shame attenuation is used to get a person to talk about something that might be really shameful, something that they may feel very ashamed of, something that's very stigmatized, which suicidality is. So you might want to ask a question around normalizing that suicidality or normalizing that behavior that is so shameful. So, it's not surprising when you're under so much stress in your life to begin to talk about or think about suicide. How much are you thinking about that? How much are you thinking about suicide right now? You'll find that when I use these validity techniques, I'm trying to avoid yes or no questions. I'm trying to move towards open-ended questions that will allow the person to respond in an open way and will engage them in conversation and keep them talking versus just yes, no. You get yes, no questions, that kind of is a killer for the conversation, as I'm sure you all know. Gentle assumption is really one that I use a lot. And the thing about these techniques is the more you practice them, the better you get at them. So using these in your conversations, whether it's with your clients or with your family members, can be really helpful. Just practicing is helpful. So gentle assumption, what you're doing is you're assuming that a behavior is already occurring. So if you're thinking about suicide, you're assuming that the person is already thinking about suicide when you're meeting with them. They may not be. It's possible that they haven't thought about suicide. It's possible they've never thought about suicide, although probably pretty unlikely given the context in which you are seeing them. And so you make the assumption that they are that they're feeling suicidal. So what I might do is tie some of these together. I might say, it's not unusual for you to, if you're feeling stressed, to feel suicidal. Tell me about your suicide thoughts, or tell me what ways have you thought about attempting suicide, or what ways have you thought about what means or methods have you thought about for suicide, or how often do you think about suicide? Now, if I say to somebody, how often do you think about suicide? They may say, I don't ever think about suicide. Okay, that's great. That may be true. I'll move on to some other questions then. But if I say, how often do you think about suicide? One of the things that happens is that it gets them opening the door to the fact that you're there with them. You likely know that they're thinking about suicide. And it's amazing how responsive somebody who's really holding on to this intense feeling of wanting to die will share that information when they're given that kind of gentle assumption that it's happening. Symptom amplification is again a really great way to kind of get at behaviors that are stigmatized. What you want to do is you're looking for kind of the upper limits in the range of a behavior. So if you're using this when it comes to drug use, you want to say something like, so how much cocaine do you use a day? An 8 ball? 8 balls, think quite a bit of cocaine, it's unlikely that they're going to have been using that much, although it's possible. It's more likely that they're using something under that. How many bundles of heroin do you use a day? 12, 13, I don't know. I mean, I don't know what the upper limits are for heroin right now, but it's you want to get that high end of the anticipated behavior, so that when they actually are talking about what they're using, they feel more comfortable expressing what is actually the behavior that they're engaged in. How many suicide attempts have they had in your life? 75, 100? Oh, no. I've only attempted suicide maybe, I don't know, 5 or 6 times, right? So you're allowing them, by amplifying the symptom, you're allowing them to discuss what is a stigmatized behavior. The 2 others that I want to share with you are the denial of the specific, which denial of the specific is a great way of kind of capitalizing on specific behaviors when somebody is avoiding talking about them. So, you might say, gosh, how many times have you attempted suicide? Well, I've never attempted suicide. Oh, okay. How often have you, used, thought about overdosing, or thought about hanging, asphyxiation, thought about poisoning, thought about shooting yourself? If somebody has to deny a specific stigmatized behavior, it's much more difficult than denying a large group of behaviors, right? And so again, that's a way to get them talking about that stigmatized behavior. And the normalization, again, sort of like symptom amplification, is is just suggesting that a behavior is not uncommon. You're normalizing a behavior. Sometimes when people feel very alone and isolated and sad, they have thoughts of just disappearing or dying. That's not unusual. That's kind of a normal thing to experience. How often do you have those feelings, right? And so those are all ways of engaging folks in the process of having conversations. For those of you who are probably about my age, maybe a little younger, you recognize this as Lieutenant Colombo, Peter Falk. Colombo was a TV show on NBC back in the 70s, and he had an amazing way of just kind of getting that question out in a way that allowed the criminal to actually disclose information that he or she would not normally disclose during an investigation. He was the king of doorknob comments. He'd literally be going out the door and say, just one more thing. And it's important to have that just one more thing that you're holding on to. When you're having conversations with people about suicidality or any stigmatized behavior, be open to the fact that they may not be honest with you, and hold to those periods and those pieces of the conversation that you might be able to go back around to and try to really get a better understanding of where they may be misinforming you or not giving you the full picture. These kind of work in ways around these considerations. So the just one more thing approach is important when you're thinking about the fact that not all suicidal patients are going to disclose their suicidality. There's an ambivalence, so their behavior is contradictory. They may reach out, maybe in some ways they may reach out because they're forced to, right? A crisis evaluation being done because a parent is saying, I'm very concerned about you. They may reach out and get help, but that doesn't mean that they don't have a strong desire to die. And they'll also, folks who are suicidal will partially share. They'll talk about maybe the suicidality risk around the pills that they have stashed in their cabinet, but they may not talk about the gun that they have in their dresser drawer, right? And so those kind of just one more thing questions, you want to keep going back around and thinking about, how transparent is this person right now? How transparent do I believe they are? How ambivalent are they about being here in this session with me? And are they going to only partially share information with me? Can I get deeper into the conversation by asking further questions that will help them feel more comfortable sharing more fully. Some of the barriers to disclosure: people can be very committed to acting on their thoughts. They don't want to be stopped. One thing to look for somebody who's really made that decision to die is that they're acting in ways that they might now not normally have been acting. They may have in a period of time when they're feeling depressed and hopeless, and then all of a sudden you see this kind of euthymia, an experience of maybe joy and happiness. They've made the decision that at this point, I'm going to move forward with this. They start putting things in place. They start giving things away. They start saying goodbye, and sometimes in a way that is very couched. And so it's important to be thinking about that. But people can be very, very insistent that they will die by suicide. There can be religious, moral, and stigma conflicts in terms of barriers to disclosure. Cultural conflicts can be barriers to disclosure. Use of eye contact, how you frame a question, culturally has to be based in an appropriate, culturally sensitive way, because you don't want to be engaging folks in culturally insensitive interviewing techniques. So it's important to know what their religious, moral, cultural background is. There are suicides that happen impulsively, and it isn't the ideation that drives the suicide, but really the impulsivity that does this. We see this much more often in younger people, in children, and in young adults, adolescents, that they're more likely to act on impulse. The world can seem very hopeless to a 14-year-old. There's no way of seeing what the future might look like. And if they're impulsive and they have access to a means to die, they may make a very impulsive attempt. And unfortunately, those can be lethal. And then there's kind of the barrier of alexithymia. And alexithymia is really that sense of not being able to even know what your own emotions are, to not be able to not only not talk about them, but having a really difficult time even identifying them. For folks who are really profoundly depressed, this can be true. And so when you're trying to have a conversation with somebody who really is experiencing that kind of alexithymia, it's difficult to engage them. You get very kind of stilted answers. And so it takes more work, but you have to do the best that you can. It's not always successful. So just a few things to consider, in terms of future considerations. I think it's surprising in the pandemic that people have been increasing their use of mental health treatment. Not surprising that it's been obviously through telehealth, but a lot of us have worked for years trying to get telehealth into practices, and then all of a sudden the pandemic comes around and here it is, right? It's the way that we connect with people. And so I think that that's been in many ways a real positive experience for mental health treatment. I think one of the things that we don't really know much about is how to do really good evidence-based interviewing during a telehealth session. There's so many cues and considerations when you're in a session with a person: body language, how they're moving, what they're looking at, what they're saying, those pauses. They can look very different in a telehealth session than in a one-to-one session. And so I think that there are some future considerations around how to do the best kind of practice risk assessments using a telehealth platform. I think those will be things to consider coming up. In summary, really, we have to get people through those suicidal crises. 15 minutes is about the time that a suicidal crisis exists. If you can intervene during that time, that's really critical. If you can intervene before the crisis, that's the best, but during the crisis is really essential. So if you're seeing somebody who's in a suicidal crisis, you really want to be present with them. You want to be asking those questions and be open and empathic to their experience, and getting them help as quickly as possible. Engagement strategies benefit from being culturally competent. Having cultural competency is critical when you're doing any kind of a risk assessment, any kind of assessment, but particularly with risk assessments around stigmatized behaviors. Just as I said before, just as individuals who rehearse suicide attempts, we need to rehearse talking about suicide. And so asking questions, practicing with each other is really, really important. And I think just keep talking. That's, kind of the bottom line. Just keep having conversations, keep suicide at the front of the conversations you're having with clients. As difficult as it is, the more you practice saying the word suicide and not just kind of talking around suicide or talking euphemistically, saying, harming yourself or thinking of hurting yourself, using the word suicide, if you can get comfortable with that, it's going to make your process with those folks who really are suicidal much, much better. So questions, we've got about, 20 minutes or so left, I think, in the time for questions. So I'm open to any questions that you have. I'm going to stop sharing my screen, but if you do have questions that you don't want to share here or come up later on, I'm always open to hearing questions via email, so you can email me there, kirkwoodring@gmail.com, and I will respond as quickly as I can. But I always respond to emails from folks who have been to a workshop and want to talk more. So, wow, people, look at that. So folks have questions, and you can raise your hand, or you can just shout it out. Yes, Eleanor, I see your hand.
Hi, I sent a question in the chat, but I guess you don't see that. So I had a question. I know you talked about certain categories of people, et cetera, but I was wondering, and I hate to tell you, I was wondering about this because there's some people I was talking to today, but do you think are there, in general, do statistics say that people who commit suicide are more likely to have been sad for a long period of time or depressed, or could it also be people who had done really, really well for a long time, but I've put in here that they've, like, for example, lost their jobs and now their status in the family has changed? Is that just as likely that they would commit suicide? Or, like, what is the likelihood or probability of people in that category?
Yeah, I mean, definitely economic changes, that's a huge risk factor, right? So loss of a job, loss of any kind of relationship that's been really critically important to you, whether that's a spouse, whether that's work. And then you tie in, the economic loss. Not only do you have the social loss and the connectedness piece with a loss of a job, but you also have the economic changes, right? And so that really is a huge risk factor. Does that mean that the person is more likely or less likely to die by suicide than others? A lot of that has to do with the other risk factors that might exist. Have they made attempts before? Is there a suicide risk in the family? Close friends that have died by suicide? Anytime you have close friends, family members who have died by suicide, there's, somebody who's done it, right? And so it's possible. It makes it possible and more kind of likely that you can actually engage in that behavior. And so, so those kinds of risk factors I hold on to, and I put them into the big pot and stir it all up and see what's it going to look like. And so certainly if somebody has, I didn't say this, but 80% of people who die by suicide have a substance on board. So alcohol, drugs, street drugs. So are they engaging in drug use behavior, alcohol? Are they, what are the other risk factors that continue to kind of escalate the concern? And then what are the protective factors as well? So you want to balance those out. But yeah, I wouldn't say that loss of a job necessarily makes you more likely to die by suicide, but in the absence of other, or in the presence of other risk factors, it certainly could increase that risk.
Okay, thank you. I value what you say, and I think you're right to just, unfortunately during the sessions I had with these people, it just didn't occur to me to ask them, but some things just didn't hit home right. Like, I don't truly think this person is going to go home and kill themselves, but this person lost their job. They got a new job, but it's second shift, and they are very devoted to their daughters who are young, and they're very sad about having this second shift job. And so when I talk to them about this could be temporary and things of that nature, like, there's more jobs. He has an excellent work history. He's not using any substances and hasn't for years and years. But he was very resolute about it, saying like, I'm 42, I'm just going to stay with this job now, even though it's second shift, even though it meant giving up a very important thing to him in his family.
Yeah,
And
that's
I remember that his brother killed himself about 7 years ago.
Yeah, that's a good time to use that, kind of the gentle assumption or the normalization. Gosh, I know that when people lose their jobs, it really, it can make them do things that they wouldn't normally do. And I wonder if you've thought about suicide, or how often you're thinking about suicide, right? Maybe the gentle assumption of assuming that maybe he is thinking about suicide. It's really remarkable how just saying something so simple as making a gentle assumption like that opens up a door for somebody who really is feeling that. And if he's not, he'll let you know. And you kind of, put that in the back of your aha, let me think about that, and move on with the interview. But opening up that door is pretty remarkable, at least in my experience.
Well, we've talked about suicide fairly often in the past, but more like towards the time period where his brother had passed away. But I also, before I even had this training today, I did call him just to talk about some other issues. And so I asked him if he would call me back, and I'm sure he will. Maybe not today, but tomorrow, and I'll talk to him about it then. It's okay just to ask him on the phone, right? I mean, because
Sure.
he doesn't come in again for 2 weeks.
Yeah, I definitely. Yeah, good luck. Good luck. Thanks for the question. Okay. Other questions? I can't see everybody, so okay, I don't see any others in the chat here. So so if there aren't other questions, I'll give you the 20 minutes back for your afternoon. I just want to thank you very much again for the time. Again, this is a very difficult subject. When I do day-long workshops, I just really encourage people to get up, stretch, take care of themselves. If you've had a history in your family or a history in your practice of folks who've made serious attempts, who have died by suicide, talking about it can be triggering. And so know yourself, know what you need, and know what your kind of resistance to having these conversations might be as well, because you got to work through that resistance for yourself in the benefit of your clients. So thank you very, very much. I hope to see some of you again, and don't hesitate to shoot me an email if you have questions. All right.
Thank you very much.
All right. Thank you. Take care, everybody.